Good morning, everybody, and welcome to week 2, day 1. I hope you guys are ready to take more notes and get more involved within the CNA program. If you have any questions, please do not hesitate to let us know. Let's move forward. All right, so during this session today, we're going to discuss acute care, subacute care, long-term care, and home care. What we've been talking about before from last week, we're going to go ahead and get a little bit more in depth. We're going to talk about terms used for patients in different healthcare settings and legislation, rights, and behaviors. All right, so when it comes to acute cares, we got clinics, hospitals, and surgical centers. You usually stay within these facilities from 1 to up to 3 days, depending on what happened or if you had to get minor surgery or something like that. Sudden injury or illness requires short-term stays, so that's why it's up from 1 to 3 days. Overnight is inpatient and not overnight is outpatient. When it comes to subacute care, that's a rehab center or a pain management center, and you can stay in these facilities for up to 30 days. You can be recovering from an illness and need skilled care when it's time to heal. So, this is why you have up to 30 days to go ahead and get the treatment you need, the different procedures done, anything that you need to do that won't take long but need a little more longer time, you're able to do that in these facilities. All right, long-term care. You got assisted living facilities or nursing homes. This is required for more than 6 months. Um, you got a chronic illness, an extreme disability, you elderly, or just need hospice care, and you need somebody to look after you more than 24 hours. It's for people who has medical or social or personal assistance that's needed over a long period of time. So somebody who's going to come in and make sure that medically they're taken care of when it comes to medication, when it comes to treatments or anything in that nature, as well as keeping them socially involved and making sure their personal assistance is taken care of because they can no longer do it on their own. All right, within home cares, you got CNAs who work in the client's home or HHAs who work in the client's home. They offer managing long-term conditions because now they're in their home, they're just not in a facility, that's all. They're recovering from an illness or injury, which is usually being transferred from a subacute care, so now they need a little bit more extensive care within their home. And they just need a variety of assistance, such as light housekeeping, cooking, personal assistance, medication reminders, all kinds of things in that nature. Again, patient terminology: patients receive acute care, residents receive subacute care or long term care. Short term residents receive 3 to 6 months or long term care depending on how their disability or illness transpire. And then you got clients which receive home care within the home. You want to be familiar with patient environments. You want to know who you're caring for, where you're providing care at, what kind of environment you're going to be in, if you have team members or not, and how you communicate with your team. If you're in home care, you're definitely not going to have a team to communicate with when it's time to need a little bit more assistance when helping the client, but you definitely have a team that you can call on, and so someone will come out there and they'll help you and assist you. When it comes to the hospitals or long-term care or even hospice, you have a team. So you have somebody that you can lean on when you're in the need. Emergencies pop up all the time. So that's why they make sure there's somebody in the building that's able to help you and assist you and qualified to work right next to you. All right, legislation, rights, and behaviors. Again, we got 7 patient rights: dignity, discharge, privacy, transfer, access, grievance, and self determination. These all are important when it comes to taking care of clients because we want to make sure they get everything they can get while they're in the care of our hands, as well as we're protecting their rights. When it comes to dignity, we must treat each patient with respect, regardless of whether our patient respects us, talks about us bad, talks down on us, treats us crazy. We just want to give them as much respect as needed. When it comes to residents, they not witnessing the abuse, we don't want them to witness that. So we want to make sure everybody's in good hands. Even if you see another employee doing something that's morally wrong, we want to go ahead and correct that so the resident know we don't tolerate those kind of behaviors. Our residents shouldn't be restrained unless it's an order required, and the order comes from a doctor. If you're not a doctor and the doctor didn't say, okay, they're harming themselves and they're going to put you in harm's way, then there'll never be a restraint order. And we just must stay professional with clients at all times. When it comes to discharge, we got to let our residents know before they're being discharged. Give them a heads up notice. We do require a 30-day notice before being discharged, and it has to include a reason that they're being discharged. It can't be because we don't want them there anymore or they're disrespectful to us, they hurt our feelings, we can't work with them. No, it has to be a valid reason, like their treatment is completed, they're transferring to a different facility for further treatment, things in that nature. When it comes to discharge, medical information and personal information still stay confidential because it involves the patient, and so we want to assume it's private. They can have private communications with whoever they choose as a resident, but when it comes to us talking about information and sharing information, we definitely don't want to do that because we don't want to give the wrong information to the wrong person, or we don't want to give their information to the wrong person and then it spread around and now that backfires on us. And residents can use any form of communication to connect with who they want. So they can send and receive mails, do phone calls, emails, text messages now because everybody has a phone. So however they want to share that information, they're definitely more than welcome to do so. When it comes to transfers, they have the right to have their spot held. So if they're going for a transfer to get minor surgery or minor treatment, they're able to come back to our facility within a couple of days. So we have the right and they have the right to save their beds or their spot in the facility until they're done. When it comes to access, they have the right to access their medical records. If they want to know what's going on, what treatment's being provided that they forgot about, how much the treatment is, whether they have a written form or they've been told orally, everything that we've discussed and talked about is inside of their medical records, so they're able to access them at any time. When it comes to grievances, our residents have the right to voice their complaint. We can't discriminate against them through the process, and that's when the ombudsman will come and communicate on the resident's behalf because either the resident don't know how to communicate because they're scared to communicate, or our ombudsman will go ahead and talk to the family members and the residents just to see what happened, get their side of the story, get their look on everything that happened and transpired, and then they can go and talk on behalf of the resident so the resident don't feel uncomfortable, and then everything get handled from there. When it comes to Self-Determination Act, patients have the right to determine and make decisions about the care they receive. Again, we can discuss an emergency plan during situations that may just pop up out of nowhere so that it can be appointed and ready for it. They have the chance to appoint someone to make medical decisions on their behalf, which is a power of attorney. So it's certain situations that we want to go ahead and jump on when it comes to putting someone in power of attorney or making sure they have a living will or just the legal documents are done in time so that if anything transpire or change, we have it in place. OSHA, Occupational Safety and Health Administration. Again, they were established in 1970. It protects employees and us from all different hazards and industries. So, different final thoughts. When it comes to a nursing assistant, it's important that we observe the rights for residents. We know what place we are working in to protect our residents, what entities protect our residents, what entities protect us. The patients have a right to a 30-day written notice if they want to be discharged or transferred. They are able to remain in the facility until it's a valid reason for them to move. They have access to all of their medical records and quality care, regardless of who they are, how they treat us. They have access, and we cannot discriminate. And they also have a voice in their care plan, so if it's something they don't agree with, they can let us know. All right, emotional changes is how someone react to a situation, like a child or a baby crying versus using words to express their frustration when they become children. Coping with taking care of our parents once they get a little bit older. That's something that's always a little bit harder to do because we're not ready for that time of our life, but it's something that we have to do. Or losing a partner. That's something hard to do, especially if you've been with that partner for years and years after a time and that's all you know. When it comes to cognitive development and changes, it's the ability to think and understand concepts. So it's our memory, problem solving, decision making. It's all of that tied into one to help us maneuver through life. So we got human growth and development. There's a lot of stages that's been developed by many scientists and theorists, but they're broken down into different groups and they may be labeled differently depending on the age group or the age limit. Some changes usually depend on whether you've been describing social or emotional or mental changes or cognitive changes that we've been going through. It all depends on the person. Everybody has not experienced the same exact thing. So we want to make sure that we break it down for you. All right, we start at infancy, which is the stages of life, and we go all the way to old years. When it comes to infancy, this is from birth to 1 years old. The growth is rapid during this stage. They'll have the ability to control certain body movements, such as holding their heads up or grasping at certain things. Their teeth begin to develop and they can start getting introduced to solid foods. Crying is definitely the main form of communication, but it's different cries that we'll be able to understand to see exactly what's wrong with the child. They may mimic sounds around them and they start to develop motor skills like pulling up and sitting up, holding their head up, sometimes standing up. When it comes to a toddler, what changes are apparent in toddlerhood from 1 to 3 years old? You got physical, cognitive, emotional, and social. It's a lot of different changes that's going to be very apparent to how they're aging and growing up in life. Physical, they start to walk on their own. Cognitive, they play pretend games. Emotional, they use words like no. And social, they begin to take turns and play with others. Toddlerhood, we're going to use a large emphasis on motor skills because they start to use their fingers and muscles to do a lot of different things like build and put toys together and start to color and things in that nature. We're going to talk about a large emphasis on gross motor skills because they start to walk and run and jump and start to move around a lot more. They may be a little bit more clumsy at first, but once they get a hang of it, they're on go and they're nonstop. They show interest in playing with toys. They start to use the toilet regularly. They do have separation anxiety, so when it's time for them to start going to school or preschool, it's hard for them to separate from their parents, but that's a part of life and how we move forward. And they just start to become more independent. improving cognitively. So we're able to move around and think more and act upon others' behalf, such as our parents, when it's time to make certain decisions. Got young old, 65 to 75 years old. Some of them may retire, some people may not. It could be a good experience or a bad experience depending on how they retire or where they retire from. Sometimes we experience the death of our spouse and siblings, and that becomes a more natural thing for us. So we're kind of getting used to things like that happening, which is not a good feeling, but it's something that we have to get used to in life. Our independence is challenged, so we may require a caregiver. There's things that we thought we could do and continue to do that we just may not be able to do on our own anymore. We may need a little assistance or a push. And we still have high cognitive function, but we're going to pursue to learn new things so that it'll keep our mind going and keep us busy. You got middle old, which is 75 to 85 years old. Our sharpness of our senses start to decrease during this time. Sight, hearing, taste, we start to lose the ability to have it all, to be honest. Muscle and bone strength, they may decrease on us, and we might become a fall risk depending on how brittle our body is or how good we took care of it during our younger ages. We might lose a spouse, change our living arrangements, which going to cause disorientation. So if we're used to being in our homes for a long period of time or living on our own, and now we have to go to a facility, that's going to change how we are used to maneuvering around in life, and that's going to cause disorientation that might be a good thing or a bad thing depending on how we maneuver around. And we still got good cognitive function, but we just probably process things a little bit slower, require more time to learn new things, to be honest. When it come to old years, you 85 years or older, this is the time we're going to reflect on life. Our physical abilities are going to decline, so it's a lot that we're not going to be able to do on our own as far as moving around and getting around. You have some people that still move like they're 45 and 50, but that's not everybody. We're thinking about everybody in a whole. So we start to decrease and decline as we age. We begin to think about death and prepare for it, put things in order if we haven't already did that. It's probably going to take us a lot longer to learn new things, but if we're able to learn it, you want to go ahead and continue to push that person to learn it. Keep their mind going, keep their cognitive function intact. What is cognition? It's a thinking process, which include memory, reasoning, judgment, and language. So as long as we have good cognition, then we're able to maneuver and think still. So things that we know that's not good or changes that we see and can process, we'll be able to act on it and help someone better take care of us versus being hard to deal with and going against what someone may say that needs to be changed and we feel like it doesn't. Cognitive changes in dementia. Dementia is a group of symptoms that occur with a progressive decline in memory. You got Alzheimer's disease, vascular dementia, mixed dementia, frontal temporal dementia. There's different kinds of dementias that's going to affect us differently. When it comes to Alzheimer's disease, you got three stages, to be honest. You got the first stage, which is impaired judgment and forgetfulness. That's slightly. So you can tell when somebody is slightly losing their memory and when they're just going out of it. You got stage two, that's significant, and our family starts to notice. So we want to go ahead and act up on it more because now their short-term memory is poor and they start to get more disoriented and can't do a lot on their own or remember a lot or maneuver around the home on their own anymore. And then stage three is terminal, so it might last for months or years, and this is total care stage, so they can't even remember to pick up a glass of water and give it to themselves, or eat their own food, or pick out their own clothing. You got vascular dementia, which is a problem with memory, trouble speaking and understanding speech, depression, confusion. Vascular just focuses on how we communicate with other people. If we have that kind of dementia, we're not going to be able to communicate as well as we would like to. So certain things that we want to say, we probably won't be able to get out. You got frontotemporal dementia, which is impulsive, inappropriate behavior, and lack of concern for others. So you got people that's going to be in the facility striking at you and acting sexually with you when it's very inappropriate, or just getting irritable with you and don't have great judgment. This is frontotemporal dementia, which is possible apathy. It's loss of interest and motivation. They don't want to deal with you anymore, or certain things that trigger how they react to you. They have trouble naming things and misuse of words, so it gets a little frustrating to where they just want to lash out at you. When it comes to the symptoms areas of dementia, you got memory, which is amnesia, that's without memory, usually short-term memory. You got communication, which is aphasia, without speech. This is something that's very important when it comes to testing as well, because they may ask you about this. This refers to problems with communication. You have senses, which is agnosia, without knowing, the ability to use our five senses. Sometimes we can't recognize ourselves. Sometimes we can't remember who a person is. That's agnosia. And you got tasks, which is apraxia without doing. We just start to not be able to perform steps and necessary duties that complete tasks despite wanting to. So if I said I wanted to put on my shoes and tie them, and I just can't because I have apraxia, then that's just something that I'm gonna struggle with. Even though I want to do it, I'm not able to do it. All right, so we got a scenario. You giving care to a woman who becomes frightened of her own reflection in the mirror because she just don't recognize herself. Can you tell me what this is an example of? All right, if you answer agnosia, you are correct. It's her senses. She don't recognize herself. She don't even recognize her reflection in the mirror. She don't think she look like what she looks like because it's just not normal. It's not the person she usually sees or not the person that she remembers. When it comes to Maslow's hierarchy of needs, this is how we based our needs off of being in human life: self actualization, self esteem, loving and belonging, safety, physiological needs. When it comes to physical needs, our basic requirements to live is food, water, sleep, exercise, the ability to use the bathroom. This is basic necessities for us to continue moving and continue functioning in life. When it comes to safety and security, it's the necessity to feel safe, whether it's locking doors, having somebody to talk to, using the brakes on a wheelchair to keep somebody safe at all times. We want to make sure that this person or people that we deal with or in our care feel safe and secure so that they'll continue to trust in us and be able to let us help them in life and get through everything that they're going through. You got social needs, the need to be liked, loved, accepted. Some people feel like they are a part of a group and want to always feel like they're a part of the group. So we got to make sure that we feed their social needs. So if it's a bingo game going on, if it's a knitting group going on, and that's something that keeps them happy every day, we want to encourage them to continue to do that. Sitting with residents and talking to them, that's always a good social need to keep their mind going, to keep information flowing. We want to encourage them to participate in any kind of activities that's going on that's going to keep their cognitive function and function. When it comes to self-esteem, we just want to make sure everybody feel good about themselves. They feel worthy and they feel respected. We want to promote independence and we want to be patient. When it comes to independence, everybody has been independent for a long time, being able to take care of ourselves for a long time. So we want to make sure we continue to push that, even if it takes them a little bit longer to go ahead and complete certain tasks. We still want to push their independence so that they feel like nobody's taking over in life. When it comes to self-fulfillment needs, satisfaction with one's life, they're going to develop hobbies, they're going to develop short-term goals. This just gives them a sense of satisfaction that they're continuing to do something good with their life. They're continuing to be the best they can be in life. They continuing to do things that's going to make them better or feel better about their life, being that we're transitioning over time. So when it comes to checking our understanding of the people diagnosed with dementia, most people have which type? Can anybody tell me? If you answer Alzheimer's disease, that is absolutely correct. A lot of people just slowly, progressively lose their memory over time. You don't necessarily see the other ones unless it's something that's going on or transpired throughout life. Alzheimer's disease will hit somebody eventually. Okay, so that's going to wrap it up for today's lesson. If you guys have any questions or anything that you didn't understand that I was going through because I moved too fast, just go ahead and don't hesitate to ask the questions so that we can make sure we answer them and you understand everything that we're sharing with you. Have a great day. When it comes to gender identity, it's whether a person identify themselves as male or female. Gender identity is each person's internal or individual experience as a gender. So we don't discriminate. We respect the person's identity. We are there to care for them, not to judge them. So if it's a male that come into our care and want to be identified as a female or a ma'am or a missus, we go ahead and we grant that wish for them so that they don't go against us or have a rebuttal for anything that we say. They let us take care of them. When it comes to culture, you have beliefs and customs and values and practices of specific groups that we want to honor as well. Some of them don't celebrate holidays. Some of them wear certain clothing. Some of them use certain languages. Some have acceptable and unacceptable gestures, like some of them may not want you to look them directly in the eye, or some of them may get offended by touch on the shoulder. We want to think about them different kind of cultures so that we know how to maneuver and interact with those people. Some people have body parts that can be exposed, and some that will not be exposed. They'll be covered up fully. Who can give care to a patient or a resident? It all depends on how we maneuver and act around our clients. So we want to make sure they know who makes decisions in their family so that we can know who to talk to or who to share information with. Although we won't be the ones to share information, we're able to share information with our nurses and they can share it with the proper people so that they can handle those situations. When it comes to spirituality, the belief in something greater than mankind, we may or may not be a part of an organized religion, but that person may. And so we want to respect their wishes, respect their thoughts, respect how they feel and handle themselves. They may meditate or have prayer at a certain time of day or read certain texts from their spiritual books or maybe even exercise doing Tai Chi or yoga. We grant that for them so that they can feel like they have a place within the facility or within our staff to where they can still use and understand their spirituality and keep it going for themselves. When it comes to admission, if a person officially enters the healthcare facility as a patient or a resident, it's our duty to make sure their first impression of the facility is amazing. A lot of people experience determines how a resident or a person view to stay within a facility. So we want to be as welcoming as possible. We want to be as calm as possible. We want the environment to feel safe. We want to make sure that they have a great first impression so that that's the impression that they ride out with for the time that they're within our facilities. When it comes to welcoming, we greet the resident at all times. We always want to smile and be pleasant, explain why we're there to help them. That's the point of us knocking on the door, coming in. We greet ourselves, we acknowledge who they are, we ask them for permission before we move forward in performing any kind of duties. We build a rapport and a connection with them. We listen to their care, we listen to their thoughts, we listen to their concerns, and we go ahead and act upon them. We personalize their care. We don't treat one person like we treat the next person. We treat them as individuals so that they can feel like you have a lot of people to take care of, but you always come in here and you treat me as a person. You treat me as me. You give me everything that I need for me. You don't give me what somebody else needs. And we want to involve the patient in decision making, address their concerns, make sure they understand that this is your right. You have the right to say yes, to say no to any of these things. So I'm asking you for your permission to do anything that I have to do, and you have the right to say yes or no. When it comes to admission, before that patient or resident arrive, we want to think about what special needs they're going to have, whether it's a larger bed, whether it's a larger gown, whether it's a geriatric chair, what equipment needs to be in the room. If they have personal belongings, we want to chart that on the inventory sheet so that they won't lose it. And what personal care products are they going to need? Do they have their own toothbrush and gowns and bedpans, or will they need a bedpan because they can't use the bathroom or get up on their own for now? Will they need gowns to sleep in? Things in that nature. Here's a copy of an inventory sheet that we may work with, just to chart off what we've added or what we haven't added, what they have already or what they don't have, and we sign off on it and we give it to the nurse. When it comes to medical terms, we include abbreviation and acronyms. That's why it's important for some of us to understand what abbreviations to use and what acronyms are going to be used. Abbreviations are shortened versions of words. Acronyms use the first letter of the word to remember a list. So PRN is as needed. AMB is ambulate. These are certain words or certain abbreviations that we're going to have to know because it makes it easier for us to communicate instead of writing a word fully out on a document when we have short amount of time to document information. When it comes to acronym, RICE, we want to know that that means rest, ice, compression, elevation. When it comes to CDIPSY, we want to know that that means communication, dignity, independence, privacy, safety, infection control. All of these things play a major part in our healthcare documentation, so we want to make sure we know all abbreviations, if not all, at least most abbreviations and a lot of acronyms so that we know fire and push or pass, those different kind of acronyms. We know that, okay, this is something we need to act upon. This is how we handle this before we get it started. We're not using slang. We're going to stick the terms that's taught to us by our facility, and we just don't create our own words. When it comes to reporting, we verbally exchange a lot of information, but we also chart a lot of information within certain medical systems. So we're going to report bowel movements, we report in fall risk, we report in isolation precautions because things can transpire from just these three different kind of reports, and a person that don't have a bowel movement can be impacted over a certain amount of days, and we just don't want that. So we make sure we report every time they have a bowel movement. A fall risk is somebody who was usually walking on their own, now they kind of stumbling a little bit. We want to make sure they know that's a fall risk so we know how to maneuver around them, whether we need to assist them at times now or we need to step in and change the way they maneuver around the facility. Isolation precautions is put in place for those who may have a communicable disease that transpires from one place to another. So we need to either gown up, use appropriate PPE or things of that nature. This happens usually during a shift change, and it can happen during a shift if it's necessary. And these are based on observations, whether it's objective or subjective. When it comes to observing objectively, we use our five senses. We measured them. We felt what's going on as far as the skin feeling warm. We can see with our eyes that their eyes look yellow. We took the blood pressure, so we are the one who read 121 over 80, and we also took the temperature, which read 98.9. So it's something that we've acknowledged ourselves, and now we're observing these and we're reporting these to the nurse. When it comes to subjective observing, this is stuff that can't be identified using our five senses. They're usually speculated or uncertain. We can't measure it. Our resident told us she has back pain, or a resident has a headache, or a resident back itches. Although they're telling us these things, we can't feel it or see it physically, so it's a speculation on our end. We're just letting the nurse know. This is what our resident said. I can't really tell, but I want you to go ahead and go in and observe this to see what's going on moving forward. When it comes to changes, you got awareness, independence, behavior, vitals, which is usually important, the input of fluids and food, the output of urine and feces, the appetite and level of comfort. All of these play an important role in how we care for our residents. We are the first sign of we are the first people who notice different signs that come out within our residents. So although the nurses take care of them and medicate them, we see the changes before they do because we're working with them more closely. So we need to report all of the changes we see that do not look normal. All right, so we got a chart here that talks about different climate impacts. certain things that we're going to be dealing with, whether it's medical or physical health, mental health, or community health. When it comes to closing thoughts, residents of all ages and origins will identify and express themselves very differently. So we need to know how to maneuver around working with different people in different cultures and different backgrounds. It's just makes our job easier. It makes it easier for us to go through the day helping everybody without less frustration. We want to respect the sexuality, the culture, customs, and spiritual practices of our residents as well. Even if we don't agree with it, respect it so our day can go better. And we want to remember that the needs of our residents are the most important thing, and we should accommodate them whenever possible. So we noticed that we talked about social, emotional, and cognitive and physical changes, basic human needs, the difference between sexuality and intimacy. We talked about culture and spirituality. If it's any questions you guys have on any of those topics, please feel free to let us know so that we can address them for you. Checking our understanding. You got a nurse assistant who must care for people from a different culture. How should a nurse assistant handle this? We want to seek to understand each person as an individual and then accommodate that person's preferences whenever possible. Just making sure that they get what they need, we make them comfortable as possible, and we understand them the best to our abilities. Which action would be the best appropriate time to meet with a resident's safety and security needs? So, what will we do to be best appropriate when it comes to meeting our residents' safety and security needs, pretty much? If you answer B, the answer is correct. We want to answer that person's request for help as promptly as we can. We don't want to see a call like come on and wait 15, 20 minutes before we go answer it because that could put them in harm's way. So anytime they have a request or they need us, we want to try to get to them as appropriately as we can in the most appropriate time as possible. I know things get a little bit busy, but if we can get to them right away, that just helps us keep everybody safe and keep the problems and issues down. All right, you guys, we have did it. We've made it to the end of the week. Again, QR codes are here for those who have more information about the program moving forward, more questions about things that we may get within this program that we're providing to you guys. If you guys have any questions, like I've mentioned before, make sure you don't hesitate to ask.